Hi, everyone. This is Margie Giuliano. I'm the Medication Safety and ADE Regional Lead for the New England QIN-QIO, and I want to thank you for joining us for today's webinar entitled Promising Practices Incorporating Pharmacists into the Care Continuum. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute during the presentation, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleagues, Stephanie and Nayara, will be monitoring the chat window and responding to your comments in real time. So don't be shy. We'd love to hear your thoughts about what our speakers are saying and how you are addressing medication safety in your own practice. It's important to note that today's speakers have no conflicts of interest to disclose. Our speakers today include members of the chart teams from 3 different programs: the Addison, Gilbert, and Beverly Hospitals team, the Hallmark Health System team, and the Milford Regional Medical Center team. Before we get started, I wanted to share that this work was funded through the Massachusetts Health Policy Commission CHART program. The Health Policy Commission, or HPC, is an independent state agency that was formed by the Massachusetts Cost Containment Law in 2012. HPC monitors reform in healthcare delivery and payment systems. HPC currently has 2 investment programs, one of which is CHART, Community Hospital Acceleration, Revitalization, and Transformation. The CHART program is being implemented in 2 phases over the course of 5 years. During the first phase, the program focused on activities aimed at priming system transformation. During the current phase, the goal of the program is to promote care coordination, integration, and delivery transformation, advance electronic health records adaptation, and information exchange among providers, increase alternate payment methods and accountable care organizations, and enhance patient safety, access to behavioral health services, and coordination between hospital and community-based providers and organizations. Our learning objectives for this program are to describe how incorporating pharmacy into the care transition scheme can decrease hospital utilization, identify the role pharmacists can play in addressing the needs of vulnerable and/or high-risk patients, and explain strategies to overcome identified challenges. As I shared during this call, we want you to use the chat feature so that we can hear from you. So please chat in with questions and comments on the presentation, your initiatives and experiences, as well as what you might need some assistance with. So let's start by seeing who is on the call. Please type in your name and role, organization, and state. I thought we would start the program with a high-level overview of the challenges we face when patients transition from care setting to care setting. As you can see from this slide, once a patient enters the care cycle, it really does take a whole team to ensure that they get home safely. For example, when patients are discharged from the hospital and have new prescriptions to be filled at the pharmacy, who has reviewed the patient's medication profile to ensure that what's been prescribed is appropriate, effective, and safe for that patient? Is there a home health agency that we need to hand off information to? Have we spoken to caregivers? Is there family support or community support for this patient? As you all understand, this is a moving target, and there are many moving pieces to coordinate to keep our patients safe, especially during transitions of care. The big question is, why should we include pharmacists as part of our care team? I think the statistics speak for themselves. While medications are invaluable in treating chronic disease, we know that when used or prescribed inappropriately, they can cause adverse drug events. ABEs contribute an additional $3.5 billion to U.S. healthcare costs and are responsible for approximately 280,000 hospital admissions annually. What I find significant is that up to 1/4 of these events are preventable. We can also see that when patients transition from hospital to home, that 49% of the time there are medication discrepancies, from drugs being omitted to duplication of therapy, etc. And 29% of the time there are still medication discrepancies found 30 days post-discharge. Not a good situation. Medication management is a challenge for healthcare providers and their patients, especially during transitions of care. As medication regimens become more and more complex, and as the drugs themselves become more complex, the management of medications by a skilled provider becomes more critical. 49% of adults in the U.S. have more than 4 prescription medications at home to help with their chronic conditions. This number rises dramatically in the elderly population. Who better than a pharmacist to engage in medication management? Pharmacists bring a unique skill set to the table. The pharmacy programs offered today are extremely focused on drug entities, metabolic pathways utilized, how drugs affect disease, and most importantly, how they impact their patients. Pharmacists graduate with a doctoral degree which really validates their expertise in medication use. That being said, it is important in this day and age to really level set everyone on what medication therapy management is and how it is different from comprehensive medication management. As these processes, which are the tools of our profession, have evolved, even many pharmacists are not fully aware of the differences in these two terms. So medication therapy management, or MTM, is a broad term used to describe a service or group of services that optimize therapeutic outcomes for individual patients. We see some of these services most often being provided in the community setting, as pharmacists are well positioned to identify eligible patients from their database. For example, they can identify high-risk patients that are eligible for certain vaccines, such as flu and pneumonia, and then they can administer these vaccines. They can also identify patients that are not adherent to their medication regimen. Taking an opportunity to discuss some of the challenges for that patient, they can then work with the patient to identify solutions. Perhaps it's the cost of the medication that's the issue, or perhaps they're coming to the pharmacy too frequently and they might benefit from medication synchronization program. Additionally, as part of the Medicare Part D program, pharmacists can also provide medication therapy reviews to targeted populations that are identified by the Part D plan. These reviews are somewhat limited in the sense that the pharmacist doesn't have a complete amount of information to provide planning for that patient. Pharmacists also participate in performance target or incentive programs as well as cost optimization programs. So these are all the different services that fall under MTM. Comprehensive Medication Management, or CMM, is a system-level, person-centered process of care provided by credentialed pharmacists to optimize the complete drug therapy regimen for a patient's given medical condition, socioeconomic conditions, and personal preferences. This is the more in-depth management program that is typically part of an integrated care team in a physician's office or organization of group practices. Pharmacists have access to more data to support their care process, so they have access to the medical records, lab values, etc., that really help, again, to paint that full picture. How do you know if a patient's medications are effective if you don't have the lab values that validate that? Typically, communication to the care team is much easier as an integrated member of the team, and that doesn't always occur when we're looking at MTM. Much of the fragmentation of our healthcare system is due to poor communication between providers. In the pharmacy profession, we see fragmentation of communication between pharmacists, where pharmacists in the hospital don't often speak to pharmacists in the community, either at retail settings or in our skilled nursing facilities, and that goes back and forth. So I'm excited to be learning more from our speakers today about their projects and how they might offer some insight. Again, we'd really like to hear from you today, and if you or your organization is doing something to incorporate a pharmacist, either somewhere across the care continuum or in your practices, please share with us. I mean, the programs that we're going to be hearing from today are primarily hospital-focused, so we'd love to hear if you're doing something as well. So please share in chat. With that, I'm very excited to introduce our first chart team of presenters from Addison, Gilbert, and Beverly Hospitals. Presenting today for the team is Nikki Patel, and she is the Transitional Care Clinical Pharmacist at Addison Gilbert Hospital, working under the CHART program. She works as part of a multidisciplinary team where the goal is to improve quality, build efficiencies, and reduce costs by addressing gaps in the care of patients with complex social, behavioral, and medical needs in the community. After earning her doctorate in pharmacy from the University of St. Joseph's School of Pharmacy, Nikki worked in the community pharmacy setting. This is where her interest in helping socially complex patients with medication adherence and other medication issues was developed. Her other team members include Pooja Patel Susar, who is the Transitional Care Clinical Pharmacist at Beverly Hospital. As a transitional pharmacist, Pooja aims to connect her patients with various services and provides education regarding medication management in an effort to increase compliance and adherence to treatment regimens. She earned her degree from the University of Massachusetts College of Pharmacy. Christine Bertoli is a transitional care clinical pharmacist at Beverly Hospital as well, and her team manages the care of high-risk patients by improving communication and promoting care coordination between the hospital, skilled nursing facilities, and community-based providers, with an overall goal to improve the affordability and quality of care. She earned her PharmD from Northeastern University. So, Nikki, I will now turn the presentation over to you.
Good afternoon, everyone. This is Nikki. So the high-risk intervention team aims to reduce 30-day readmissions for patients with a history of recurrent hospitalizations, social complexity, or need for palliative care services. We have certain enrollment criteria for our patients, including them being high utilizers, which means greater than 4 admissions in a year, 30-day returns, or that they're socially complex, meaning that they might have Medicaid, Medicare under the age of 65, homeless, or have a substance use disorder. So I'm going to get into a specific patient case and describe interventions that were made to help everyone understand the specific pharmacist role within our program. So GT is an 85-year-old female who presented to the hospital due to cough and shortness of breath and had a recent admission for pneumonia. She was enrolled in our program due to being classified as a high utilizer, so again, that means 4 or more admissions in a year. This patient was discharged to a SNF or a skilled nursing facility, and certain medication changes were made, and those are reflected in the table below. And once she was discharged home from the SNF, certain medication changes were made, which are in the table below. I'll refer back to these tables when I'm discussing the interventions that were made. So first, medication reconciliation was done when the patient was first admitted. So this involves the pharmacist verifying fill dates of medication, home medications listed, and also checking the PMP for control fills. Pharmacy technicians also help pharmacists obtain home medication lists from patients when they can. Second, upon patient discharge to the SNF, pharmacists provided transitional support by ensuring the correct medication list went over to the SNF. So oftentimes we find that some of the medications patients have been on at home may fall off of their medication list when they are discharged. So it's really important that we follow them when they're discharged so we can make sure the correct list goes over. And third, with this patient, once he was discharged from the SNF, a home visit was conducted with both the patient and the patient's daughter, who is her caregiver. This is actually where most of the medication issues were discovered. So referring back to the previous slide with the medication changes, there were a few changes in the patient's prescriptions. And upon the home visit, the patient's daughter expressed concern to the pharmacist because she was worried about how to make those changes since her mother's medications were pre-filled in a medication machine. So the daughter was pretty overwhelmed because she needed to add and remove certain tablets and she wasn't sure which one was which. So the pharmacist called the control center to have the medication machine unlocked. So this gave the pharmacist the ability to access the specific dosage cups and make the adjustments needed. So these changes included levofloxacin, an antibiotic being added on for 3 more days, and then so that needed to be added into the cups. Digoxin needed to be held for 3 days while she was on the levofloxacin to avoid any medication interaction. And then the digoxin was also increased to 250 micrograms during her SNF stay. So after being held for 3 days, that needed to be increased within her dosage cups. And also, in addition to this issue, the digoxin itself was confusing to the patient's daughter because of the way the strengths were written. From her Walgreens prescription bottle, it was written out as 0.125 milligrams, and then from the SNF medications, it was written as 125 micrograms. So this was confusing to her, and she wasn't sure if it was the same thing. So the patient was able to educate her that it was the same strength, but it was just expressed differently. So after going through all of this, the proper adjustments were made within the medication machine with the help of the pharmacist. And another issue that was brought to the pharmacist's attention during the home visit was that the patient was prescribed Duoneb solution. This was actually prescribed within the hospital, and it was continued from the SNF as well. But the patient's daughter informed the pharmacist that she actually did not have a nebulizer to use the solution. So the pharmacist intervened by contacting the patient's pulmonologist to initiate the appropriate paperwork needed to have a nebulizer delivered to her home. So the result was that the patient was educated and the caretaker was also educated through the home visit. We helped to avoid medication errors by helping them adjust the dosage cups within the med machine. This was really important because the patient was very overwhelmed with this. We also helped to ensure completion of the entire antibiotic course and also helped to avoid any medication interactions by removing the digoxin for the 3 days. We also helped connect the patient to services, specifically limb care, to get her the nebulizer, and providing the transitional support in between when the patient was at the SNF was also helpful. So our recommendations based on this case and other work we've done is that it's really important to dig deeper with some of our high-risk patients. And hold visits are often critical in identifying these medication issues, especially in our example. The patient seemed to be well taken care of. I mean, she had a medication machine at home. She had a very involved daughter, but when the pharmacist actually went into the home, that's when we realized that there was a lot of, she's feeling very overwhelmed, and there was several errors that could have occurred had it not been for our intervention. And transitional clinical support is also crucial in preventing medication errors, just to make sure that the medication list is staying the same throughout. So this is a brief overview of our program results so far. So it shows a return rate by discharge disposition. The left-hand side shows Addison Gilbert Hospital. The right-hand side shows Beverly. So if you focus on the far most right bars, the blue bar is our return rate from a SNF in the prior year of 2016, and the red bar is our return rate so far from SNF this year. So as you can tell, the patient return rates from SNF discharge have decreased in both locations, and this is, I believe, largely due to our intervention. And this graph shows the return rate by population. If you specifically focus on the enrollment return rate, which is the red line, this line shows the effect we have had on our target population for the patients that have actually been enrolled within our program. So overall, we've had over 30% decrease at both locations. And in addition, as I mentioned before, we have pharmacy technicians that also assist us, and small sample of face spots revealed that 46% of potential errors were actually reported by them, so they make a huge difference as well. At the end of my presentation, but if there's any questions, please feel free to contact any one of us. We'd be happy to answer any questions. Thank you.
Thank you, Nikki, for that great presentation, and it looks like you had some great results. I would now like to introduce our next chart team from Hallmark Health, Carol Clacton and Amy Lemieux. Carol is a licensed independent clinical social worker and executive director of COACH, the Collaborative Outreach and Adaptable Care at Hallmark Health, an initiative funded by the Massachusetts HPC CHART program. COACH aims to improve care for patients with high utilization of emergency department services, obstetric patients with active substance use disorders, and patients with a history of near-lethal opioid overdose requiring an Narcan reversal. As former system director for behavioral health at Hallmark Health System, Carol has over 30 years of experience in behavioral health care delivery systems. She's a graduate of the University of Massachusetts at Amherst and Rutgers University Graduate School of Social Work. Presenting with Carol is Amy Lemieux, who is a pharmacist at Hallmark Health System. Her transition to care work includes two programs, one focused on emergency department revisits reductions, which is part of the COACH program, and the other on 30-day hospital readmissions reductions. Previously, Amy was a clinical supervisor at Hallmark Health and a clinical pharmacist at McLean Hospital. She is an adjunct faculty member of MCPHS University and Western New England University College of Pharmacy and serves as a PGY1 residency preceptor at Hallmark Health. Carol?
Good morning and good afternoon, everybody. Thank you for your attention. We're delighted to talk about COACH very briefly. COACH focuses on high utilization of the ED as defined by 10 or more visits in 12 months. We have a fabulous multidisciplinary team consisting of community health workers, nurse practitioners, social worker, pharmacists, and primary care doctors. We have some underlying foundational tenets for our program for our target population, particularly for the MVPs, which are what we call multi-visit patients, and that is that the patients are not failing the system, that the system is failing the patient. So we really look at both micro and macro level issues when we're trying to go forward with improving the lives of our patients. We also subscribe to a push model of care rather than a pull model of care, meaning we push all of our services out to patients in their homes, in the community, rather than pull them into the office to see us here. Our primary aim is to reduce ED utilization by 20% for our multi-visit patients. Amy will speak about some specific examples and about the role of the pharmacist.
Hi, everyone. Thank you very much, Carol. We thought we would go through some of the lessons that we're learning about incorporating pharmacists into our high-risk patient care team. One thing that we've learned is that practicing in the home-based environment moves us away from the traditional fix and hope model that most of us have become very comfortable in practicing. This is where you make a recommendation on either a treatment team in a hospital environment or maybe directly to a patient in a retail environment, and you hope that that recommendation sticks. In our longitudinal way of practicing, where you're visiting a patient every week, this is very different, and it really makes the medication management the responsibility of the pharmacist. And by this, I mean the responsibility for all aspects of the medication. Can they get the medication? Can they afford the medication? Do they even want to take the medication to begin with? This is a great opportunity to create a bridge between those two areas of our profession that have previously functioned on islands, the hospital and the retail pharmacist. And a great way to utilize the skills from both the hospital pharmacist and the retail pharmacist to deliver a high quality of care to our patients. There's also tremendous opportunities to utilize students and residents in a transition practice. These new practitioners and young learners are so proficient in evidence-based MTM recommendations that are geared directly at decreasing utilization that they quickly become a valuable resource. The most important takeaway lesson that we've learned is that there's an important role for a pharmacist really on any high utilization or complex care team. It's not always a traditional role, as we'll highlight with our patient case, but it's an important role nonetheless. So our patient case really highlights what happens when you visit someone in their home and build a relationship, both with the patient and the other practitioners that are also dealing with our complicated patients. So patient 1, or P1, was initially referred to us for assistance with an electric pill box. Through this conversion, we got to know his DNA and began regular consults with the DNA that takes care of them a few times a week. Also opened up to us about his drug-induced hallucinations that he was experiencing from his Parkinsonian medication, and we had several consults with his neurologist to facilitate starting Nuplazid or Pimasertib. His hallucinations improved for a couple months, but eventually returned and became much worse, eventually resulting in an admission to our Jerry Psych unit. This is really one of the biggest advantages of our coach program. We base ourselves both in the community and the hospital. So the hospital teams know our names, they know our faces, and this really serves for some instant validation when one of our patients are in the hospital. We coordinated care with his inpatient team. We met with the team every day. We were at all the family meetings, all the team meetings, and suggested a switch to clozapine. I can say with confidence that this would have been 2, maybe 3 admissions in a typical situation before we discontinued Nuplazid and started clozapine. But our close relationship with his outpatient and inpatient practitioners really facilitated us being able to be advocates for this patient and really get him what he wanted, which was to be completely hallucination-free. We carried the treatment into the community. We started clozapine in the community, set him up with a pharmacy. We also did some negotiation with the PCP and the neurologist, neither of whom wanted to prescribe the clozapine, to hold the patient for the 10 weeks until we could get him with a psychiatrist.
Hey, Amy, this is Morgan Gardula. How are you? Are you supposed to be advancing the slides?
No.
I just wanted to make sure.
Yep, they should be advancing.
No, Carol passed Amy the ball, so Amy, you have to actually advance the slides.
Okay, sorry. I could see them advanced on Carol's computer. Now I can see them on mine.
Yeah,
that.
because she's a speaker, she can advance behind the scenes. So if we can just have you advance them, Amy, that'd be great.
Okay, no problem. It should be on the page.
Thank you.
Here.
That is correct.
Patient 1 was successfully transitioned to clozapine and remains hallucination-free. He has been out of the hospital for 3 months with no admissions to the hospital or the emergency room. The prior 3 months, just for sake of comparison, he had 5 emergency room visits that resulted in 3 inpatient visits, and he was definitely on our trajectory to become what we refer to as a super user. So probably more important than, any of the cost savings or anything associated with this was he had disclosed to us that he had a lot of fear about going to any sort of social environment where he might mistake a hallucination for a person. So really the big victory in this was that he has begun leaving his home for the first time in years and actually made his first visit to the local senior center just a few weeks ago. So just a few closing thoughts on the role of a transition and care home-based pharmacist for anyone thinking of incorporating this type of pharmacist into their high-risk care management team or practice. These are some takeaway thoughts. This is a very different way of practicing from a traditional pharmacy practice. The role is very fluid and changes every single day. I definitely don't think even visiting the same people week from week, there's different challenges that come up every week. It's also a tremendous opportunity to expand our role as pharmacists. The flexibility piece is key. I think, you need to be ready to do what is needed at the moment. But it is a tremendous opportunity, I think, both for us as individuals and the practice as a whole. And because results are so important, I will turn it back over to Carol for just a brief look at our results thus far with the coach program. I'm not seeing Carol on my screen, though.
Hey, Mark. Did you need help, Amy?
Nope, I got it. Thank you.
Okay.
Excellent.
Perfect.
Thank you, and I can't, as the director of this program, I can't underscore enough for the audience the importance of Amy in the role of the pharmacist on the team, what it's brought not only to our patients, but to the other members of the team who value her expertise, who turn to her, and I'm sure that we would not have the impressive results that you can see here without having pharmacists as a part of the team. So what this slide shows, just very briefly, is that the work that we're doing has been effective. We measure ED utilization 6 months before enrollment and 6 months post-enrollment. The left half of the screen shows a historic, essentially a control group, that what would happen to the same types of patient if there was no intervention, and the right side shows what happens for patients who are enrolled in the program, and there is a relative reduction of 38% in ED utilization 6 months pre and 6 months post-enrollment. So a very effective program with, as I said, pharmacy can't be underscored enough as an important contributor. So if anyone has any questions or comments or wants to email us, please ask during chat or send us an email at this screen. And now it's my pleasure to turn it over to the team from Milford.
Thank you, Carol and Amy. What a great presentation. Again, very impressive results. And now I'm going to turn the program over to our last speaker, Charlie Zaghi. Charlie is a clinical pharmacist on the high-risk mobile team at Milford Regional Medical Center. This team is an initiative also funded by the CHART Investment Program. The team's goal is to reduce 30-day readmissions for patients with a history of frequent hospitalizations. Charlie has experience in both hospital and long-term care settings, providing care for the geriatric population in multiple states. He received a doctorate in pharmacy from the Massachusetts College of Pharmacy and Health Sciences. Charlie, I pass it on to you. Thank you.
Thank you. So, hi everyone, my name is Charlie Zaghi, pharmacist at Milford Regional Medical Center, 145-bed hospital in Central Mass. And for the past couple of years, I've been working on the CHART Phase 1 and 2. Our target population at the initiation of CHART Phase 2 was 352 high utilizers, which are defined as 3 or more inpatient stays in the past 12 months. Our primary aim was to reduce 30-day readmissions by 25% for patients with 3 or more inpatient discharges in the last year by the end of the 24-month measurement period. Ultimately, that would also help us with our CMS readmissions as well, since many high utilizers fall into both categories. So our team, there are 4 members on our team, referred to as the high-risk mobile team. We have Kim, our palliative care physician's assistant, who, in addition to being a great PA, She also authored a book titled Chasing My Tomorrow, with all proceeds going to charity benefiting young adult cancer patients. Karen, our nurse case manager, Denise, our social worker, and myself, Kim, Karen, and Denise are wonderful at what they do, and I definitely can't do my job without them. And we have our wonderful program director, Annette, who is also Director of Quality Management here at the hospital, who has gotten the program up and running for us and has been patient with us for a couple of years now. Here I'm going to talk about our daily team schedule and how we work with each other. Kim, our physician's assistant, is almost always in-house unless needed for a consult in the community. As for the remainder of the team, Karen, Denise, and myself, we alternate who is in-house and who is on the road making home visits. In my case, I tend to be in and out of the hospital in order to assist with discharges for high utilizers, and that's usually around the time multidisciplinary rounds are done, which is around 11. Every morning, we get an automatically generated report of high utilizers that have presented to the hospital within the past 24 hours, both obs and inpatient. One thing that has been very helpful for us is automatic palliative care consults for our high utilizers. As for workflow, our ED software identifies high utilizers. Then the case manager of the ED will notify the in-house team member of high utilizers in the ED as they come in. At this time, our MedRec tech in the ED interviews the patient and connects with me. Then they go on to update the MedRec in the computer. The in-house team member will do a meet and greet with the patient and will provide them with our contact info and obtain their approval for our follow-up post-discharge. That team member will then assign the most appropriate team members to that patient. Some patients might require closer follow-up with Denise, our social worker, or Karen.
Bob was going to do it too.
I'm sorry?
Hi, it looks like we have somebody on the line that has unmuted themselves. If you could just please make sure your line is muted. You can press *6 to confirm that your line is muted. Thank you. Sorry about that. Go ahead.
Oh, thank you. So different types of interventions. We do, as I mentioned, an in-house meet and greet. We do it by phone as well, usually within 24 hours of discharge. We do home visits, so we also attend those within 24 hours of discharge. Obviously, holidays and weekends are exceptions. And we do follow-up in skilled nursing facilities and other facilities. So my role is to collaborate with physicians and mid-level practitioners to optimize medication regimen for our high utilizers, assist the patients in overcoming barriers, obtaining medications, anything from financial to physically being able to obtain them, in which case we set them up with delivery services, work with community partners to improve patient outcomes. Our team and the assigned team members are usually listed on the referrals upon discharge in all script. And anytime our local skilled nursing facilities, our VNAs, our PCP offices have medication-related questions about high utilizers, they can reach out to me directly. We do not have our own outpatient pharmacy here at the hospital, so we team up with community pharmacies to better assist patients if they require special packaging, such as medicine on time, or pill boxes that have reminders, and connect with smartphones or other devices and such. Here's a quick overview of what the touch points look like, on a monthly basis. This is from our June data. Whatever touch points are provided by myself, the social worker, the case manager, or the MedRec technician, and our PA. So we have, a little bit about the multidisciplinary collaboration, mostly with our community partners out in the community. We're really fortunate here in that we have a great relationship with community partners. We hold monthly meetings with them, including SNFs, assisted living facilities, PCP offices, and VNA. That's once a month, the first Wednesday of the month. And those meetings are very valuable in that they allow our team to know our partners better and what they can offer our patients, while allowing them to be more familiar with our team as we share patients with them or follow them in their facilities when needed. This really helps us avoid medication discrepancies that may occur when patients are discharged from us to SNFs or from SNFs to home. It also helps visiting nurses reach out to me directly with medication-related questions. Our team also meets every Monday with our program director, an ED physician, a hospitalist, and the director of case management to discuss high utilizers admitted the previous week. We also meet weekly with our program director every Friday to discuss any changes or updates to the team's process or workflow. Here's just a quick glance at our CMS penalty from this fiscal year to the next, going down from 2.56% to 2.11. So that's definitely a significant difference. And I guess, as for recommendations, we find community meetings to be very valuable, as I mentioned earlier. Definitely get to know what resources are available in the community. This obviously applies to all disciplines. In my case, I'm very fortunate that I have Karen and Denise who pretty much know everything out in the community, and they're definitely a great resource for me. And medication management certainly plays a key role in reducing readmission. This has been proven over and over. And here's my email address if you guys need to reach out to me. And I'm going to turn it over to Margie right now if you have any questions.
Thank you, Charlie. Again, another great presentation with good results. So now it's time to open it up for discussion and questions. So Morgan, can you remind people how to unmute their lines? And while we're waiting, Nayara and Stephanie, perhaps you can get some questions ready that I see are in chat. Looks like our chat's been very active. So Morgan, can you just tell people how to unmute?
Sure. So to unmute your line, you can press *6. And then make sure you haven't also used the mute button on your phone. But again, it's *6.
Thanks, Morgan. So Stephanie and Nayara, what do we have in chat?
Hi, so we have a question in regards to how many full-time staff does Addison have dedicated to their transitions of care team?
Sorry, could you repeat that question?
Yep. How many FTEs do you have dedicated to your transitions of care?
Sorry, how many what? I guess we don't understand.
Full-time
Oh, full-time employees.
Oh.
Okay. So currently we have on the Addison Gilbert team 2 full-time employees and 1 part-time employee. And we just actually hired another community health worker who's going to be full-time too. So it's 3 and then 1 part-time.
So full-time pharmacist at Addison, a full-time social worker, a nurse practitioner that's part-time, and a full-time community health worker. In Beverly, the population's larger, so we have 2 full-time pharmacists, 2 full-time social workers, and 2 full-time registered nurses.
Great. Thank you. Any other questions? Questions from the phone? Hearing none. Stephanie, do we have another question in chat?
We do. We have a question from Maureen, and it's how long do you do weekly home visits? And this was for Carol from Hallmark.
How long do we do weekly home visits? I'm not sure whether that means how long are the home visits, which are usually an hour, or how long we continue them. We actually do not have an endpoint for our program, so we have followed some people now for 18 months. We do use a risk stratification model to decide how often we should have contact with people, but every patient is contacted generally once a week or more by phone, and most patients are seen once a week in a home visit either by the community health worker along with one of the clinicians or a clinician by themselves.
Great, thank you. Again, I'll ask if there are any questions from the phone. Okay, any other questions from the chat, Stephanie?
Yes, there's a question from Nancy. Are you billing for these services through Medicare? And I think that might go to all the participants. All the speakers.
So let's start with Addison. Are you billing?
No, we're not.
How about at Hallmark? Oh, go ahead.
It's a chat grant, and we're not set up to do that type of billing at this point.
So just as a follow-up, so is the chart grant is covering those services at this time?
Yes, correct.
Okay. And is that the same at Hallmark, or is Hallmark set up for billing?
No, we're not set up for billing, and I will say that as of right now, the home visits for the pharmacists would not be covered in billing, I don't think, but we are covered by the chart grant for the services right now.
And Charlie, how about with Milford?
So no, we do not bill. Like myself, the social worker, and the case manager, we do not. Our palliative care PA, I think she bills for inpatient visits, inpatient consults. But that's something that's done. I don't know how that works, but I know that we do not. We're funded through chart.
This is Carol again. Would you mind if I just added one more comment? Although we don't bill, what we have come to see is that we're beginning to move into the accountable care organization, population health strategy, and having a pharmacist and all of the really high-risk teams will be very cost-effective under that model, where we'll be moving away from fee-for-service billing anyway.
That's great. I think I would like to just take the opportunity to ask a question as facilitator. So I guess, I think one of the big questions we always hear from on a lot of our programs is how do we make this sustainable once these grants are gone? And I think, Carol, you started to touch on that. Do any of the speakers have any other comments as how, what happens at the end of the grant program? Charlie, I'll start with you. You have any thoughts on that?
So at this point, we're just kind of waiting to see what's going to happen with our team. That's September 30, like end of September is when we're due for renewal through the hospital if we were to be sustained. So it's in the budget, but we're just kind of waiting on our board to meet and decide what the plan is. But in terms of what could be done to kind of help facilitate the funding, I don't know if there's any type of billing that could be done, such as NTMs in terms of a pharmacist or licensed social workers can also bill. So I'm not sure if that can help generate any profit enough to sustain a team. But at this point, we're just waiting to see what happens.
Thanks, Charlie. How about Nikki at Addison? Do you have anything to add?
Yes. So our joint hospitals put a strategic plan board together to review all the results up to this point, and they have interviewed various people in the community that are clinical that we work with, and also with the patients that we've touched. And so this board has actually evaluated all this information that's brought to them, and they do see the value of what our team has brought to the hospital. It's not currently in the budget for our team, but they are working on trying different avenues of how to sustain us. So we're in that process right now. We're hoping that the hospital will be able to sustain us.
I am. Great, thank you. Any other additions, Carol, before we move on to any other questions?
No, just a word of encouragement that for anyone who's looking at thinking about either sustainability or building a program, it's key to not only look at what you might save in avoiding readmission penalties, but also in more subtle things such as ED patient flow, if you're in fact reducing ED and inpatient admissions, and increased productivity and satisfaction among primary care providers who tend to respond very favorably to these types of programs.
Thank you, Carol. Steph, are there any other questions? in dispatch?
There is. This is a question from Francis, and it's, do you foresee the role of the pharmacist being permanent and spreading across the nation? And I think that might go towards the panelists, all panelists.
So, with you?
I think we hope that the goals can be used in various different settings in various different hospitals, but that is the goal of the program, to get hospitals to basically retain the team and our roles currently.
I think that the more we show how valuable the pharmacist interventions are, I think the more other hospitals will also take on a similar sort of service.
Great.
Hi, my name is Carol Friedman. Can you hear me?
Yes, we can, Carol.
I'm a clinical pharmacist working in an ACO managed care environment, and I actually work with Christine, Pooja, and Nikki. And I'd like to say from the ambulatory side, we see the value. We're very fortunate in that we're funded by the ACO or a health plan. I would hope, as Nikki mentioned, that we would be able to sustain their role, because for those of us in the ambulatory side that do transitional work as well, we truly see the value, and we look forward to it, the program continuing. I do think as ACOs and whether they're Medicare and or Medicaid grow, I think we'll see more establishment of pharmacists in these roles.
Thank you, Carol. Thank you. Are there any other questions from the phone? Jeff, I think there's a couple more. I think we have time for one or two more from chat.
Sure. Here's a question from Sally. Have you been able to show a return of investment for specifically the pharmacist? So what metrics, care gaps, or interventions have been shown to be most effective?
Who would like to start with that?
This is Carol from Hallmark. It's very difficult to show a return on investment because we're not billing. Many of the return on investment discussions we've had are as much qualitative as they are quantitative. But again, in terms of having discussions with our finance colleagues, it's difficult at this point without anything on the cost side of the ledger.
Thank you. How about from Addison and Beverly, especially with the whole discussion on the ACO showing any positive return on investment?
I think because we as well don't bill, so it's kind of hard to really show return on investment. But I think as we presented in our presentation, the charts show that since the team has been involved with the enrolled patients that we picked up, the return rate of the population has decreased. But there's no way to really show an investment because we don't bill.
This is Sandy Aikens, the clinical administrator for the Beverly and Addison Gilbert chat grants. I just would like to make a comment on the return on investment issue, because the strategic planning group has extensively reviewed that, and the issue is who saves the money and where has the return on investment been. With the decline in the readmission and Medicaid readmission rate, we can clearly see that we have saved hospital dollars, but the hospital itself might not have recouped that money. It might have been a savings on the state ledger side. Clearly, if you were moving into an ACO model of care and population health, that actually would be a return on investment. But when the hospital is trying to make a decision on sustainability, it comes down to who saves the money. Just on the strategic planning side of the questions that came up earlier, the hospital for Beverly and Addison is really looking at two options for sustainability. One is to fund the continuation of the grant itself to keep the staff employed because they value the work that they've done so highly. And the second would be to look at a transition to the current ACO model, especially if there's a Medicaid ACO contract. And those are two of the decision points that they're looking at right now as we speak. But the return on investment dilemma, I've been calling it, is a challenge because it's like, where has the money been saved? We've saved money. We've decreased admissions. We've decreased length of stay. We've increased flow, as other people have mentioned, but it's hard to really calculate where those savings have gone to. Who saved the money?
Thank you for those comments. At this point, we will have to stop with the questions, so please continue to put them in chat, and we can always get back to you. We'll answer the questions as best we can in chat. So I think some of the key takeaways from today is communication is key. Pharmacists, I think, are recognized for their unique skill set in med management, and they can bring some added value to improve medication safety and reduce hospital readmissions. Again, the question as to how to fund and keep these programs sustainable are always the questions that we struggle with. That being said, if you are interested in working with the New England QIN-QIO, here is a list of the med safety leads in each of your states. Any way that we can support you, we're certainly willing to help, so please reach out to any of us. For the pharmacists on the call that are looking to get ACPE accreditation, the code is pharmacist. You'll be able to enter that information when you complete the session evaluation, and please give us at least 7 to 10 days to upload those into your e-profile account. Others who complete the evaluation will receive a certificate of attendance. And I will now turn it back over to Morgan.
Thanks, Margie. As you can all see from this slide, the New England QIN-QIO is now on social media. So please connect with us on Facebook and LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. As Margie mentioned, when you close out of the webinar today, the evaluation will automatically pop up on your computer. If you could please fill it out, we would greatly appreciate it. Again, that's how you'll get your ACPE credits as well as the certificate of participation for today. If you don't have time to fill it out right now or you're sharing a computer with somebody, you will receive an email tomorrow containing the link to the evaluation as well as the link to the event page on our website. As we mentioned at the beginning of the webinar, and I think a few times in chat, the slides from today's webinar are currently posted on our website, and within the next few business days, a recording and transcript will also be added. So I think that's all I have. Thank you to all of our speakers for a great presentation, and thank you everyone for attending. Have a wonderful rest of your day.
Thank you.
Bye, thank you.
Thank you.